So for our next speakers, actually, I'm going to call them up. We have Dr. Alexandra King, Sharon Clark, who's actually going to be replacing Gabe Lafond. So please come up. And just for some housekeeping items, I want to acknowledge our elders actually again who are here today. I mean, it's always important to acknowledge our elders that are present at our conferences. And can I actually get a couple of mics up here, please, for the presenters, because I know we're going to have a couple of questions, and I just want to make sure that they're on the table for them as questions that are coming from the floor. And then just on the program, just to remind folks that the concurrent sessions that are actually going to be happening after this particular plenary session, we're going to actually break out folks again in ballroom A, B, and C. And after this session, I'll speak a little bit about who's speaking in those areas. So please, if I could get the speakers to come up, that'd be great. Dr. Alexandra King is the CAMACO chair. Sharon Clark is the lead for First Nation Métis Health.
So hello everybody, my name's Alexandra King, and I would like to take and acknowledge this territory as being Treaty 6 and homeland of the Métis people. I am very appreciative and want to pay my respects to the elders in the room. To begin with, let me see, there we go. A brief thing about me. So I am a member and citizen of Nipissing First Nation. The people in this picture are my maternal grandparents. Desmond was an Algonquin from Timiskaming First Nation, and Mary was Ojibwe from Nipissing, as well as having Mohawk from Oka. The baby that is being held is my mother. And I found this quote that was written by the Jesuits about the time of contact, and they were very impressed with my ancestors, talking about the Nipissing, and saying that if the Nipissing was not a free man, an independent man, then there was no absolute freedom or independence on earth. So these are my ancestors, and we've been known historically in the East as go-betweens, traders, and also as mystics. So one of the things that I am working in is HIV and hepatitis C, and I also work at the intersections of drug use, incarceration, homelessness, and so on. I deliberately studied internal medicine because I wanted a lot of breadth and depth in my medical knowledge, and therefore I also have the opportunity to be doing things like diabetes research, heart health, and cancer, and so on. Now, all of these things are what I would consider way downstream here, which Malcolm King presented yesterday, talking about these being end manifestations of colonization. The reality is that I actually consider myself a wellness researcher, and we're doing research in land-based healing as well as culture-based healing. And sometimes this is in the area of HIV or hepatitis C, or working with people who are using drugs. But other times it's even more upstream. So I'm working with 3 different groups of Indigenous youth, and this would be sort of in public health speak, either primary prevention or health promotion kind of research. And we're also doing some what I guess we would call theoretical foundation work, working with various elders and knowledge keepers across the country, learning from them how they think we can be learning from the land and healing from the land. So in fact, rather than working down in this space here, I see myself as working up over here in the land-based healing, and even back here in the resiliency strategies and so on. So I saw that I was on this program as speaking about access to care, and I knew I'd be following Dr. McKinney, and that, of course, she'd be doing a brilliant job talking about the many health challenges of our northern communities. And what she's talking about actually affect many of our peoples in rural and remote communities throughout the country. And so as an example, one of the projects that I'm working on is what's called the Drum 2, and this is looking at a shared model of integrative care. And so in this case, this is based on a model that was developed by one of our Treaty 8 communities on the Alberta side, and things that they were looking at as being part of a shared model of care. And they're talking about primary care providers, and these are not just the doctors and nurses, but they're also the community health reps and various other people who are involved. They saw mental health and wellness as being really critical. Specialist support, and it tends to be coming from the urban centers. Community health and wellness centers being critical part. They saw community leadership as being critical to everybody's personal health and wellness. And then also, of course, and I mentioned them last, but certainly not least, the elders and healers. And so this is one model where we're working with individual communities to help them develop community plans for health and wellness, and then seeing what sort of supports we can be bringing in. And so earlier this week, as I said, I was up in northern Alberta, Treaty 8 communities, and we were also meeting with Métis Nation of Alberta. So that's one aspect of access to care. Another area of my research deals with peer support. And so these are people who have lived experience of a particular condition. In this case, it's HIV or hepatitis C. I'm also working with peer support around people who are using drugs. And when you're talking about peer support, it's actually a spectrum, or tends to be. So we have people who are doing outreach, and they're the ones who are really going out to people anywhere in the community and finding them and connecting them and working with them to see how they might be able to engage in care. And then we have the peer navigators, and these tend to be the people within the healthcare system. So once we can get you into the door, then these are people who help you negotiate and work with you to understand what are your care needs and so on, and make sure that these are happening. And then at the other end of the spectrum, you have peer mentors, and these are people who will take and be working with people who on their healing journey may go from being homeless and involved in various crimes, perhaps a sex trade, to be supporting a drug habit, to getting into a more stable environment, and now then helping them get housing, maybe helping them complete education, various other things. And so you have this spectrum, and it's really quite interesting research that we're doing, not only on the impact that the peers have on the care that is provided, and basically they're almost serving in this two-eyed seeing role in which they have understanding of the medical community because they've been there, they've done that, but they also have an understanding of what the people are going through because they've also been there. So they're able to bring this together for people. But the other thing is that the peers themselves need a lot of support. So you can't just bring in people and not be providing them with the training and other things. And so this is another area that we're learning a lot about. However, what I thought might be a little bit more interesting than talking about access to medical care is instead talking about access to Indigenous wellness care and what that might look like. And so in this case, this is actually a model from a paper that we'll be publishing shortly in the area of hepatitis C. And in this, what we're looking at is if in fact you were to be redefining wellness from an Indigenous perspective, in fact what you see is that the mainstream healthcare is just one component of people's healthcare, and that there's all of these other components that people are interested in bringing together. And so that becomes really important when we're talking about wellness. And so, in fact, one of the questions that we've been pondering is, what is an Indigenous wellness system? So Dr. McCoke has talked yesterday about the Indian health system and how it continues. But in fact, instead of designing a system based on pathology, what if we were to be designing a system based on wellness? You know, what sort of staff would you be having? Certainly you'd have some doctors and nurses, but we'd also have, healers, we'd have Scapio, you'd have various other people who would be critical components of this healthcare. Wellness care. What spaces would it be? Without question, we're going to have some clinics, we're going to have some hospitals, but you're also going to have things like sweat lodges and other places of ceremony. You'd have land-based healing and so on. That would be part of what we would be doing. How would we structure it? It's no longer these 6-minute appointments with family doctors or even 45-minute appointments with specialists. You would have to be conceiving things very, very differently. What are the approaches, the various treatments, and what are the medicines that we're talking about at this point? And as Veronica was saying, food is medicine. Our songs are medicine. We have various plants and so on. We have ceremony. All of these things, how do we bring them together? And then the last point is indicators. So, if we're talking about wellness, is there a way that we can understand how it is working? And so one of the things that I've been doing, and this is a project that actually started well before 2014, but with this group it's an international group on Indigenous health measurement, and they've been meeting now for about a decade, maybe a dozen years. And so they're looking at things like morbidity and mortality indicators. And in fact, from this group, last year we published a paper in the Lancet looking at global Indigenous health. And so we were trying to look at how are these indicators looking for Indigenous people throughout the world. But one of the things that came up, and it was Malcolm King who first suggested this, is that for a lot of community, we're not interested in pathology. We're not interested in, the numbers of people and how bad we're doing. Rather, what really interests us is our wellness. And so we ended up coming together for a 2-day meeting in October 2014. This was on Coast Salish territory. It was in partnership with the First Nations Health Authority of British Columbia and the Canadian Institutes of Health Research, as well as then this international group. And so what we were looking at were wellness indicators. And so the questions that we were really considering are, what is wellness and how do we define it? And understanding that, in fact, we're defining it differently for each and every community. The way that we understand the world and life and wellness is going to be different if you happen to be Nipissing like myself versus Dene in northern Saskatchewan versus coastal in BC. And so therefore, how do we define wellness? And if, in fact, you could define it, then how would you go about measuring it? And what are appropriate wellness indicators? What are mediators on this? And if we could measure wellness, what do we do with this information? How do we take and use this to help individuals, families, communities? How do we design healthcare systems? And so from this meeting, we ended up creating a synthesis document. This was Chris Macklin, who is a Métis student doing his MPH. He's almost done it now. And so we had 9 presentations from Indigenous speakers from Canada, Australia, New Zealand, the US, as well as Norway, our Sami colleagues. And so in this analysis, what we pulled out were some really critical factors that were common across Indigenous people in these different countries. The importance of cultural connectivity, the importance of relationships, and this is relationships within the person with the family, with their community, with the world around them, as well as with ancestors and future generations. Taking a life course approach to wellness, so understanding that as children we may have very different wellness indicators than when we're in our teens, adulthood, and so on. And then really looking at Indigenous determinants of health. And I use Indigenous determinants of health rather than social determinants of health, because I think that not only are we affected by the same social determinants of health as everybody else is, but in fact, as Indigenous people, we have colonization that is absolutely impacting our health in so many different ways. And so from that, I'm sorry, this didn't turn out that well, and it's because a lot of the characters are with different accents and so on. This was a meeting that was hosted by the Maori, and so this was in follow-up to a meeting in Atlanta and then the meeting in British Columbia. And so again, we were pushing forward on what is wellness and so on, and how would we be measuring it. And this is an international collaboration. But one of the things that I thought was really important coming from this meeting, and actually Sharon was there for this, which was really lovely, is that we had the real privilege and pleasure of spending the day with Sir Mason Dury. And for those who don't know who he is, he's a Maori psychiatrist who was among the first Indigenous doctors that graduated in Aotearoa or New Zealand. And he was among the first people to actually write in English academic journals, if you will, about the importance of indigeneity, and that being an Indigenous person should not be a deficit, that in fact this was something very positive. Being grounded in your culture, knowing your language and so on is really critical to our overall wellness and should in fact be protective. And so, when he was at this meeting, he was talking about how it was important for us to be measuring wellness from the perspective that as Indigenous healthcare providers and Indigenous centers and so on, we take and we think we're doing things differently in different ways for our patients. And therefore, how can we be showing that when I'm managing somebody's blood pressure, there's actually improved results? I may get to the same numbers as a non-Indigenous doctor or a non-Indigenous facility, but it's important that we're also seeing what other impacts I may be having on this person's wellness. And so he was talking about how the measures really need to be shaped around a set of values that Indigenous people hold dear. And that is the affinity to the land, the capacity to live culture, self-management, etc. That comes back to the self-determination notion, and then the equitable participation in society. And so from his perspective, these were some of the really critical elements that we needed to measure as part of determining how we would measure wellness. The last thing that I'm going to leave you with is a tetra pitch that Malcolm and I featured in an article that was published in The Lancet in 2009. And this was talking about the Indigenous determinants of health. We were basically looking at what are the causes of the causes, if you will, for ill health. And this was made by one of Malcolm's grad students at that point in time. And I think it's a really beautiful painting. And she starts off by talking about how long ago, before the settlers came, Indigenous people had lived in peace and in harmony with their natural world, and they were very healthy, they were well. But with the settlers came urbanization, and what you saw then eventually was the Indigenous people having their spirit crushed, colonized, and so on. And so we end up in this state here. And that now, she's feeling very much like we're heading into this third wave with this resiliency, the reawakening of Indigenous culture, spirituality, the strengthening of Indigenous people. And what she foresaw was that eventually we would get to this fourth picture, the yellow one, and that is where we would be in a new state of balance with the natural world, well, once again. But this time, not only would we have the strengths of our Indigenous ancestors and wisdom from the past, but we would also be benefiting from, in fact, the different medicines and so on that the Western system have brought forward with us. So I think that there is, in fact, a journey that we're on, and I would really like to see us be moving more towards a wellness system. Thank you.
Thank you, Alex. So I'm actually going to call Sharon Clark, lead for First Nation Métis Health. She'll speak to access to health, so please welcome Sharon Clark.
Thank you. I thought, wow, this is a pretty hard crowd to follow. So I want to leave you with an image. This morning, as I was getting ready for work, I had washed my hair and I had a blue towel and I twirled it up and brushing my teeth, and then I happened to look up at the mirror and I looked like a Smurf. My ears were sticking out and I had this pointy thing on here. So, anyways, not Grandpa Smurf? No, not him. Anyways, as my image for this morning, I had to laugh. But anyways, we're here to talk about access to health, and as you probably know, I'm one of Gabe's team. He has a very large team, well, I wouldn't say large, but a big team right now that he's collected over the years. And when I think about when I started, it was probably a year after Gabe had started. We only had 3 employees plus an admin. So to move to where we are now was a real accomplishment on Gabe's part. I think Gabe kind of represents the idea of ingenuity. If there's a way to do it, he will do it. So that's kind of where we'll start out with. So for the first slide, I just want to give you a picture of our staff. It's from all those different areas on the star. So our staff has a lot of personal experience, a lot of lived experience, a lot of different kinds of education, and we all fit together into the team. And of course, we don't always get along, but we each have our special areas and our knowledges and strengths that we add to the team. And on the left there is, top left, Gilbert Kuistep and his son Neil, who I think you've met on our day when we're unveiling the reconciliation flag for the commitment to the calls to action. And then underneath that is our cultural spiritual room at St. Paul's Hospital. And over there is our team. And then, of course, the treaty flag saying that we are all, or the treaty medal saying that we are all treaty people. Okay, so this is a team. Sorry. So this is a team as it is now. So at the very top, we have our director, Gabe Lafond, who is now the executive director. But we have 1 ER navigator now, which we never had before. We have a navigator at RUH and 2 at St. Paul's Hospital. We have 3 spiritual care cultural support workers, 1 connecting to care, 2 residential school health supports, and 4 representative workforce, and 2 leads. And you might have met Tanya LaFontaine, she's around here someplace. Her and I are the 2 leads for the First Nation Métis Health. Okay, so access to health, as you all know, is more than just having the services available. Sometimes if we're raised in a system that we create that system based on what we know. So when people create the system, they want to have services that will to provide to people. But what they don't add into that is pieces like, for example, some of the barriers. What are those barriers? How can we address some of those barriers by how we organize the team? What do we do about cultural differences in our system? Why is that causing a problem? So all of these things people don't always assume or always know how to work with. And a lot of people do not have background in around cultural self-awareness. They don't have a background in their neighbors, even though their neighbors might be New Canadians, they might be refugees, they might be First Nations or Métis people. A lot of people don't cross those kind of unseen lines. And the people that do are the people like the people that are in this meeting right now, people that aren't afraid to come and look at different ideas and to see what they can do in their old system. So I just want to acknowledge all of you for being here and for being part of developing a system that is going to meet the needs of all of us in Saskatchewan. So as a health system, we have failed. We've failed to respond, and that has led to increased costs, subpar health outcomes, repeat visits. I can tell you the whole story, increased healthcare costs, all of these things, and that's because we haven't responded in a way that's not only culturally safe, but meets and reduces some of those barriers. So here's what we're dealing with in the health region. We have people who are, yeah, let's do it, and we have people who are saying, no, that change is uncomfortable and we don't want to do it. So we have those things, battling within our systems. And we are going through real change right now in the health region. And as part of that change, we have a lot of change that we're trying to promote through the TRC calls to action, through all of the different pieces, trauma-informed care, all of that. We're trying to slip that into this huge change movement. So you can imagine how not only difficult that can be, but also that it provides a tremendous opportunity to actually do these things at a time where some of those doors are opening and there's cracks happening, and it's a real opportunity. Okay, so what we do at the First Nation Métis Health primarily is transforming the care experience for people and also providing culturally responsive care. In addressing the care experience, we look at addressing structural and systemic biases, and a lot of it is looking at policy and how we can address policy, and even starting to suggest policy. But we have to be because we're internal to the system, we can start moving toward having a policy. We don't have to say to people, how come you don't have a policy? Do a policy. We can say, okay, we can get that process moving within the system. And that's a benefit of being inside the system and being knowledgeable about all the structures that are in place. And as well, I have to also say that within our system, we have over 150 First Nation Métis nurses. We have 300 plus CCAs and LPNs. We have frontline workers. And these are people outside of Gabe's team, but that we consciously work to connect with. And because we've worked to connect with that, our retention level is on par with that of the general employee population. And as well, we have at least 3 First Nations and Métis physicians in the system. We have PhD pharmacists. We have a lot of different people. So we're moving along, not to mention dietitians. So we're really moving along, and each of us is working very hard in our specific area. Yes, we're in a system, and yes, we have little fences around the work that we do. But because we're all working toward the same thing, and we're all doing our little part in wherever we are, and as well as having that overall Indigenous health view, I think that really is making progress happen really quickly. So just quickly, working for an equitable health system that works for everyone, addressing jurisdictional issues. As you know, there's a lot of jurisdictional issues between the federal, the provincial, First Nation, all of those things are jurisdictional issues. Having us in place and knowing what those are and how to help smooth over those areas is a real plus for the system, to the point where they can come to us and say, we're having this problem, this patient has to go for surgery out of province. How do we work that system? How do we ensure they have funding? How do we ensure they have escorts? How do we do all of that? So we've been able to help with that. Also culturally responsive care, and this is the work of our representative workforce primarily, creating that culturally safe space for people in a good way. So providing workshops to people to discover what are my cultural lens, how does my background contribute to the way I do business, and how can that help me see how other people work and how can it make work better. So it's creating what people are calling here those ethical spaces where we can have those discussions freely and openly. Also the Indigenous health model guided by Indigenous cultural traditions and languages. All of those pieces are really important. When we first started along this journey, which I'll just say in a little bit, the work that we were doing was guided by communities, elders, and I know, and I have to say this, that our whole team is really committed to doing things in a culturally appropriate way, and that our backgrounds are merged into one team that is really working and I'm not sure how people will take this, but kind of indigenize the health system in a good way. How do we make sure that the good things are made part of the system and the structure? Because we don't want to disappear and then the next day everything goes back to the way it was. You can't do that. You have to work in that system. You have to put things in place to make sure that it continues. Okay, and then of course trauma-informed care that people are talking about, and I think Alexandra is going to be dealing with that one. Okay, so quickly, the Aboriginal Health Strategy, 2010. It was Comfy, Kiniston First Nation, STC, the Friendship Center, and others in the community who came together to develop the first Aboriginal Health Strategy. And these were the teams, and these are the themes. And these themes are the things that still underpin all of the work that we currently do, whether we're talking about transforming the care, transforming work experience. Partnering is a huge piece of what we do, building sustainable integrated system, and fostering research, learning, and innovation. All of those are still part. And that partnering piece, that's expanded to be a kind of a huge engagement area. Okay, so we've gone to this Awaken the Power of Change, which is a little more complex, but we did this specifically because we have to work within a system. And when we're working within a system, we have to have models and practices that other people can look at and say, okay, that's logical, that's evidence-based, that makes sense, in order to set our space firmly within the region, or within the health system. So those are the 7 categories in there, and as you know, those are common sense places. You have to have leaders committed to change. You have to integrate it all into the systems. You need to ensure that patient-provider communication is respectful and culturally safe. Your care delivery and support mechanism have to be in place. You can't just have a patient discharge and then boot them out the door without making sure that they have everything for a good outcome. Workforce diversity and training, an important part. People need to see themselves in the caregivers that look after them, whether you're a New Canadian, a First Nations, a Métis, a Ukrainian, or whatever. You have to see that in your system. So it's your health system. And also community engagement, another huge part. We wouldn't be where we were if Gabe hadn't made real inroads to say we need to ensure that our communities know what we're doing. We need to make sure that our communities are behind us, and we need to make sure that we listen to what the communities say and that we build that into our plans. So we're working to do all of that. So we've done a few different engagements with communities over the years that we've worked into our plans to make sure that we're starting to address. We're putting in place those steps that will enable us to get to that point where we address the different issues. So when we're facilitating cultural safety and access, we have some things that we do right now. We have our cultural supports, we have cultural advisors, we've scheduled smudging at all different sites, and people come to that, not only First Nations patients and families, we have employees that come, we have people who are never experienced it before and want that experience, and we do try to provide some training and education while we're doing that, because we know it's really important to have our allies, to have our supporters within the system, because that helps us move faster to put things into place. Leadership and partnership support's really important in order to do the work that we do, having the chiefs involved, having the communities involved, have them know that if they have issues, they can come into the health region and talk to us. We want to have that discussion. We know that over the years there's been a lot of reports about racism, incidents of racism, incidents of poor discriminatory care. Well, now we can address those through our patient and family, or our client rep. We can address those, and we can take those as far as they need to go in order to address those issues. But people have to talk about it. If we don't talk about it, we don't know what those issues are or where those pockets still exist that we need to do some work with. Navigation and IRS supports. Navigators, we have navigators now within the system. We have 3 navigators and a lead for that department, as well as we have Indian Residential School Supports, which is an externally funded program, and that was a very important piece for the work that we do. Not only does our Indian Residential School health support workers provide that cultural guidance for us, but they also provide support for our patients, whether the patients are in palliative care or whether they're going through difficult times, whether they've been triggered by their experience in the healthcare system, or by prayers or different pieces like that. Like, for example, and you never know who is affected by residential school. Like for myself, I'm at least a 3rd generation residential school attendee. But there's other people within our system who have that experience. We need to have people on staff who understand that, who've been there, who've been wherever Aboriginal people are, so that we can take that experience and we can use it to improve the system. Policy, research files. We have research files because research is an important piece for us. We need to have research to back up some of the things that we've been saying all these years. The system often doesn't take your word for it, so we need to have research that says, okay, why are young males leaving our emergency room at rates higher than the general public? Why is that? Why is it that our length of stay is longer? I mean, a lot of these things we're looking at and determining, but there's a lot of other things that researchers that we work with are looking at to improve the system. And the research guidelines we developed, because we were concerned too that sometimes research is done not for us, but for the researchers' benefit, so that they can write another paper or they can make a name for themselves rather than helping us. So when we do the research, it's reciprocal. We have guidelines that says how research work with us. It's not only that we have community members, because we're in an institution. So how do we do that? Well, we want to have Indigenous researchers, if possible, on the team. We want patient and family advisors on the team. We want leaders on the team. We want a lot of things, and that's spelled out in our research guidelines. So I was really pleased to hear that some communities are also developing their guidelines, and I think that is awesome. That is kind of where we need to go, because we need to protect our people and make sure that research is helping us. Policies, I said a little bit about policies earlier. Cultural competency, these are the ones we have, cultural competency and representative workforce. So we have a policy that says we We have to have a representative workforce, and we have to provide culturally competent services. We have a smudging policy, and we're working on a violence protocol that says we're going to look at this a little bit different. Instead of saying, well, you bad person, we're going to tie you to the bed because you're acting out, we're going to say, okay, why are they acting out? What is going on here? Are they being triggered? Are they afraid? All of these things we need to look at. And Matthew, who's one of our residential school health supports, has been really key in moving that forward, because it's a really important piece, because it's about the care of patients within our hospital. Commitment to the TRC calls to action. The Saskatoon Health Region, we are now the Saskatchewan Health Authority, but the Saskatoon Health Region had signed commitments on behalf of St. Paul's Hospital and the other critical care sites to implement the calls to action on health. So we're still working on that, and St. Paul's Hospital has done some amazing things. They're doing a mural on the main floor as you walk in. That's educating everyone who comes in about what the calls to action are, and also doing some community engagements, and they've got education. She's committed to educating everybody who works in the St. Paul's Hospital, from your maintenance workers all the way to your doctors. Everybody, she said, is going to be trained on a continual basis. So it's not going to be just this year and then after that we forget it. No, this is an ongoing thing because it is so important. And then this is just an example of what we've tried to do within the hospital. And this is kind of my second last slide, so I won't be much longer. But what we've tried to do is have a wraparound piece. I'm not sure you've heard about the tubal ligation review. There was a report that came out about tubal ligations performed in the health region. It's a public document. So what we wanted to do is, okay, how are we going to address this? And to the health region's benefit, they stepped up to the plate and they said, okay, we have to address this. We have to ensure that people within our system are safe. And they called on Gabe to come and help them move toward that in a good way. So we've got wraparound services. We've tried to bring in our cultural, spiritual supports. We've got, of course, our advocacy for the health and residential school issues. We've got all the different pieces in there. Navigators, the leadership is involved, community services, families, all of those people are involved, and we've got a committee that's working on the calls to action that come specifically from that report. In the environment, there's also the non-insured health benefits transformation within Health Canada too, and I used to work for Health Canada. And I was going to say I've been around, but that didn't sound very good. But I used to work for Health Canada, and within Health Canada also we have people who are working toward trying to change the system. So when we talk about the federal government or the provincial government, I always think about those people working in those systems trying to change things, just like we are trying to change things within our system. And like you're trying to change things within your systems, whether you're at the university or whether in your community, we're all working toward the same thing. And I like this group because we are all kind of working in that kind of headspace. So there's the TRC calls to action and the UN Declaration on the Rights of Indigenous Peoples, Jordan's Principle, the federal government response to the TRC, the Child Welfare Transformation that's occurring through the Ministry of Health, Mental Health and Addictions Action Plan that was about 2 years old, I do believe. It's still there. Missing and murdered Indigenous women, that inquiry that's going on. The 60 Scoop action that's just coming to fruition there. And the Saskatchewan Health Authority becoming one system. So you can see there's huge amounts of change occurring. And every one of us, I think, have an opportunity to be part of that change and are part of that change. I don't want people to think that they're not, but every one of us is really important for that. And then questions. So thank you.
Thank you, Sharon. Great presentation. So as Sharon was actually talking about the staff within First Nation Métis Health Service, I was actually sitting here thinking, one of our admin support, one early morning, she was running late. She comes walking into the office at St. Paul's Hospital. So if you visualize this, she's coming down the hallway. Everybody that she's walking around saying, good morning, good morning, good morning. And she was wondering, well, why why is everybody saying good morning and why is everybody, giggling? So she comes into the office, and one of my colleagues likes to curl her hair in one of those old-style curling rods or whatever they use for women's. I apologize if I don't describe that right. But anyways, she walks in, and we tell her, Roseanne, you didn't finish your hair. And she goes like this. And then she left all of her rolls in her hair, and so she was so embarrassed. So I thought I'd just share that story. So we have some time for questions. So I encourage the audience. I mean, we had some fantastic presentations done by our physicians, our community leaders, and of course, the community of Sharon, who's leading the First Nation Community Health. So is there any questions from the audience that have for our presenters? And I believe we have some folks who have mics out there that will run to your table if you have any questions. Okay, we have a question over here, right in the front.
You guys are doing a tremendous amount of work, and I know that you've actually been engaging in this work for quite some time because the health region has contacted me a few times, but I'm wondering how the amalgamation is affecting your work that you've already done and how the new health region will either translate what you're doing, because this to me was kind of local to Saskatoon. Will that translate beyond Saskatoon and kind of inform the entire health region now? And will these be things that we can see in our, I don't know what we're going to call them, our local areas, even though it's just the same health region?
Okay, I think we've been thinking about that for quite a while. How can we translate some of the good things that we've done to the other health regions, or to the other areas? Because one of the things too that we also recognize is other areas have been doing some great things too. So how can we then work to promote the good things that other areas are doing and build those into our overall plan for Indigenous health in Saskatchewan under health? So I think that's I think that's what we're looking at. How do we do that? Because we do want to promote the things that we've done. We want to promote the cultural competency policy, the smudging policy. We want to make sure people have cultural, traditional areas in their hospitals. I know Regina Hospital has one, and I know somebody had some difficulties accessing it. However, that place is there and it's available, and it can be used for people who are to do ceremonies for people who have passed away or suffered losses with their children, or just to do ceremonies for their own wellness. And they also provide, I do believe, some traditional medicine in that. And that's another thing that I didn't mention, but we've also started getting requests for use of traditional medicine within the hospital. And we have been doing it kind of on the kimooch in terms of teas and things like that, but some physicians are really supportive and some are not so supportive. So I don't know if you want to say anything to that.
Thank you, Sharon. Thank you for the question, Julie. So provincially, actually, the Ministry of Health, through the transition team process, we did an engagement right across the province where we went from far north to La Loche all the way to as far as Muskogee and even further. And we heard from our communities that they'd like to see more of that culturally appropriate services being provided in our acute care sites. So down south, for example, in Native Health Services in the former Regina Coupel Health region, they actually provide culturally appropriate services where they have elders on staff, they have navigators as well. So, and they have a cultural space that they also provide patients that want to have access to more of that traditional care. And if there's any smudging or any pipe ceremonies, feasts, whatever they need, they accommodate the patient and the families that need that. And of course, Eagle Moon also has their elders that provide the support, for traditional healing. So they're able to connect that support. And we down south as well, we have All Nations Healing Hospital, which provides that culturally appropriate care. And in fact, we have physicians working with their elders or traditional knowledge keepers and charting the work that they're doing and collaborating and supporting that particular patient. So, I think it's important to note there are in certain catchment areas they are providing that service. In the north, however, in saying that, we've heard that there are challenges in terms of that culturally appropriate care, even though when you think about, 85 to 90% of the population in the north. So what we've heard from our communities in the north, that they'd like to see more of that collaboration, but it all comes down to the budget. So that's part of that dialogue we need to have with the leadership in the north, and of course our leaders that have been appointed for the northern catchment areas. So certainly there's a lot of development and opportunity going forward. Any other questions on the floor? Oh, sorry, go ahead.
Mine is kind of stemming from that, but in community and working in pharmacies, we're often encountering individuals who have experienced personal trauma or still experiencing cultural trauma. And should we be directing them maybe back to the health regions? Like I'm working in Prince Albert, and so looking for a little bit of guidance as to what kind of resources or access to resources that we should be having on hand in pharmacies to be able to provide patients when we know that we are lacking in the ability of giving them that consultation at that time, but certainly being able to direct them the right way.
So were you directing that to any one of the panel members or all? Okay. Go ahead.
Okay. I know there's a lot of resources out there, but a lot of people don't know what they are. Like, for example, one of the community-based resources that I have used personally is the addiction workers at the band level, NADAP workers. The NADAP workers are very under respected for all the work that they do, but they were the first ones that talk about wellness rather than addiction, and wellness in terms of all the trauma that people have gone through. So addiction workers at the community level are very qualified, but we also have, through Health Canada, we have therapists who are available to First Nations people. We have provincial mental health services. There are some limits to those services right now. However, I think as we move forward, we will be working on trying to expand that as part of what I had mentioned there, the mental health provincial plan.
Sorry, Gabe had asked me to also say a word about this. And people have been talking about how I'll be talking about trauma-informed care. And I think one of the things is that often when we mention trauma-informed care, we're looking at this very much from a Western perspective. So the trauma that happens within the life course of the person, and it may be early childhood, it may be throughout their life. And certainly a lot of the people that I work with, and these tend to be people who live in the inner city, the trauma is chronic, it's repeated, it's intimate, it is stranger, it goes across the board. But the other thing though, as an Indigenous people, we have this intergenerational trauma that we're carrying also. And so I find that when you're looking at trauma-informed care, a lot of times it really is Western defined rather than appreciating what it might look like for an Indigenous person.
Thank you.